think it's great for a patient's journey, continuity of care. We see a patient right from the beginning of their journey right through to the end.
When I made the move from community pharmacy into the GP practice, it was real sort of change out of my comfort zone. But doing the ACP course really does give you all the skills that you need.
We are the first point of contact. We see so many patients with various kinds of things, and as they come to us, it's us to see and to recognize what is a problem.
I think there was more of that sort of old-fashioned way of feeling like they hadn't seen the right person unless they'd seen a doctor. I don't think I've heard that comment for a very long time now.
We can do ECGs, we can order diagnostics, so order relevant blood tests where appropriate.
Definitely seen the benefits of having ACPs in our practice. They are autonomous practitioners who are working to the absolute top of their profession.
I'm Sarah Jane Cray, Primary Care Workforce Programme Manager, part of the Kent and Medway Training Hub. An advanced practitioner is somebody who's working to the top of their licence. They've done a Master's Accreditation Advanced Practice course. These people are looking after people with undifferentiated, undiagnosed conditions. They're working autonomously and they're meeting 4 pillars of practice. So the 4 pillars of advancing practice is our clinical, our leadership, our education and our research.
We look at leadership, education, research and obviously the clinical aspect of the role. So my role in particular involves all of those 4 pillars on a daily basis. My job is quite fairly evenly distributed between those 4 pillars.
My clinical practice is that I will see, take a history, assess, manage, diagnose, interpret results, order results and progress that management autonomously.
I do feel I have a strong leadership role within the practice. I'm part of the practice management team. I lead the prescription clerk team here at the surgery. But it's also about leading on best practice. So I quite often will take clinical meetings to share knowledge with other practitioners.
I introduced a huddle in the mornings, which was about team building and team support and actually safe and risk assessment of the day. So I take leadership quite seriously and find that many of the clinical staff and admin staff will come and ask day-to-day things from me.
We would expect for people working in primary care that their clinical pillar is probably quite high and they have to do that mainly 80% of their role. The other 3 pillars are 20% of their role, and we would say that we would be looking at their education, their leadership and their research. The research can be undertaking the audits, analysing it, putting it into practice, seeing what's happening, undertaking your own research, interpreting research that's out there. So research can be defined in different ways.
We had urine samples coming into the practice in abundance and after doing an audit what we realised is that people were just dropping them off without any clinical history being taken. So that doing an audit allowed us to change the process within the practice, the patient getting a better quality of care by having an appointment to discuss whether they need to bring in a sample or not, because the guidelines indicate that dipping urine samples isn't always the best practice now.
We have nurse practitioners, we have a paramedic and myself as a pharmacist, and I think we all work very well together because we all bring a different basic skill set. So throughout the ACP course, the paramedic practitioner and myself, who are both trainee ACPs, have been running a joint clinic as well, so we can support each other with our learning.
Education is a big part because it's a continually developing role and every multi-professional individual is always developing, as in our admin staff are always developing. We've got pharmacists within the practice, we have paramedics and practice nurses, so I also see my role as developing them as well and helping support, because these are all roles that are new to general practice and evolving generally.
One of the main things that we need to actually ensure for our trainee advanced clinical practitioners is that they're getting appropriate supervision. HE does ask for a minimum of their main supervisor to meet up with them at least 1 hour a week. We have associate supervisors as well that can support them. So that could be somebody that actually has a specialism in an area that they're going to go and get some extra knowledge and skills from. and they can have that peer supervision. So it could be where you've got two trainees working together and they're supporting each other with their knowledge and skills.
I certainly get support from my colleagues, the GPs, reflecting on patients that I might have seen that day, and any that I might be concerned about or worried or want to discuss and see whether there's anything more. It's about sharing best practice and learning from each other.
There is always a duty GP available whenever we're doing a clinic that we can go to for advice, and they're happy to come and assess the patient if needed as well. My clinical supervisor is always on hand to discuss any patients, like case studies and things.
The supervision that I provide in the department ranges from very informal supervision through to more formal supervision. I would say that most of my supervision focuses on the clinical and the education pillars of the 4 pillars. I do one-to-one teaching, I do small teaching sessions, and I'm available at all times for ACPs to come and consult with me about individual cases.
Part of it is that it holds you accountable to what you're doing. Also, because we do it as a group, we have that opportunity to share our concerns and help each other resolve them, actually. So it's a very supportive environment.
I do get supervision from my doctor. I do sit down with the doctor when he's doing consultation. He will teach me how to do consultation, how to do some assessments. Like, for example, if it's physical assessment for a patient, how I'm supposed to go around it and what I'm looking for. I do get that supervision from the doctor.
There is a lot of front-end support that is required when you decide to train an advanced clinical practitioner. You have to think about the time they're going to be away from the practice, the time they need to develop their portfolio for their qualification. It is a 3-year course. It's quite an intense course. Lots can happen in 3 years, and from the point of view of the students and the practice, you need to be committed to that, because they will be out of the practice. You won't have them seeing patients and providing that care. You do need to support them.
Our paramedic practitioner, he came on board, so he does another massive piece of work for us. He does our learning disability healthcare checks, and he has developed bonds with this huge cohort of people. They would much rather see somebody they know, and they've developed relationships with our paramedic practitioner through doing the checks. They come in, they know his name, they want to see him, they have their little chats. First of all, he would meet them in the car park if they were too worried about coming in, knock on their windows, have a little chat. Now he's got them coming in, and he runs the whole programme.
As a team of primary care workforce programme managers working across Kent and Medway, we're here to support people that are actually aspiring to be advanced practitioners, that are trainees, undertaking the journey, and also once they've qualified.
Prior to starting the ACP, I was an emergency nurse practitioner, but obviously with this department becoming an urgent treatment centre, we were extending the variety of patients that we were seeing, and actually seeing other colleagues that were working at that advanced level, it really encouraged me and made me see that actually that patient journey can be much smoother. I spend some time at university every week. I have 20% off the job time. So that 20% of the time can sometimes just be consumed by university, but sometimes it's doing additional study for that module, whether it be spending time with people in other departments. I've spent time with paediatric ACPs in the hospital. I've spent time with ACPs working in GP surgery, so across a wide variety. But you can use that 20% time however you need to fulfil the module requirements. After completing, I'll be able to work autonomously at that advanced level, including prescribing, which will obviously make a difference because it means we don't need to call on other colleagues or GPs from the other side of the practice.
Initially, when they ring up and they say, I expected to have a call or an appointment with the GP, and I explain my role and say that I can trained and qualified in diagnosing and managing patients, and would they be happy to continue with the consultation. And often at the end of the consultation, the patients will say, actually, I really like that consultation and I feel that you've helped me a lot, and explained everything in detail.
The one thing I think we've noted from the point of view of the pharmacist is the fact that patients will now ask to see her because they know she specialises in particular things. And the staff, again, will also, whereas before they may have gone to the GP with a raised blood pressure, they will now go to the pharmacist and she will take over the care of that patient or advise them of next steps.
Throughout my journey, I think at every stage there's always been something more that I haven't been able to do that I wanted to do for the patient to make their journey more seamless. And I think as an ACP now, I'm able to see patients, right from the start. So I've still got GPs to refer to if it's appropriate to, but I can also manage that full level of care.
The extended roles are kind of ever evolving, and having them there is great both for us as doctors but also fantastic for the patients, because it just enables a smooth transition through the patient journey and it doesn't fragment, and the ACPs don't have to always go off and have other people do things because they're able to do it all themselves.
Patients think, oh, it's okay to talk to the nurse practitioner, she's not going to be quite as busy. Little do they know.